right, we're going to continue our discussion of the cardiovascular system now, focusing on the cardio part of the word cardiovascular, looking at the heart. So if you look at the heart, it consists of three layers. The outer layer of the heart we call the pericardium. This is just a fibrous protective layer around the heart. The middle layer we call the myocardium. The myocardium is the working part of the heart. These are the cells that are muscle cells that are actively contracting and relaxing to receive blood. The myocardium relaxes, and to pump blood away from the heart, the myocardium has to contract. So these cells need a lot of energy to do their job. We find lots of mitochondria in these cells because they're working hard to provide the energy for muscle contraction and keeping that blood flowing throughout the heart. Then we have the endocardium, which is the inner lining of the heart, which is just a slippery layer of connective and simple squamous tissue. It's kind of a specialized tissue, but anyway, it lines the heart and keeps for a nice slippery surface so blood can flow through and not clot as it would get caught in the heart. And then if we look at the chambers of the heart, we have the large pumping chambers, which are the ventricles. So we have picture the patient is facing you. So this would be the right ventricle. This would be the left ventricle. And these are the pumping chambers that pump blood out of the heart. The atria are the receiving chambers to the heart, and they are taking blood from the body and receiving them into the heart. So we see the pulmonary veins leading into the left atria, bringing freshly oxygenated blood from the lungs. And here we see in the right atrium we have the superior and inferior vena cava bringing used blood from the body. So if we look at the heart, the right side of the heart has blood that has not been to the lungs yet. So this blood on the right side of the heart is deoxygenated, and once that right ventricle contracts, it's going to send that deoxygenated blood out the pulmonary arteries, and that blood is going to go to the lungs. So here we can see in the upper right side of your screen, we can see that blood is leaving the right ventricle, going to the lungs, the capillaries of the lungs, picking up oxygen, coming back to the heart, to the left side of the heart. So both lungs have pulmonary veins bringing oxygenated blood back to the left atrium. So we can see that the left side of the heart has the oxygenated blood that's been to the lungs, and the right side of the heart has deoxygenated blood that is returning from the body and heading to the lungs from the ventricles. So you can think of our heart as a side-by-side pump. The right side of the heart pumps the blood to the lungs. The left side of the heart pumps the blood to the body via the aorta. So we can see here that blood, once it's freshly oxygenated, comes back to the left atrium. The left atria then connects to the left ventricle, and the left ventricle is going to pump that blood out the aorta and all the branches of the aorta to the rest of the body. So to prevent backflow, once blood comes to the atria, we want to make sure that blood goes to the ventricles and doesn't go back out the vessels that it came from. And to prevent that are the presence of these valves. So when the atria contract and the blood and the ventricle is completely filled with blood, we see the valves will shut. Pressure against blood, causing pressure against these valves, forces them to close. Think of it almost like an umbrella, as far as how the valves are meant to stay in one position. And if you get in a bad windstorm and that wind gets underneath your umbrella and the umbrella flips upward, that would be what would happen if someone has a leaky valve. Those valves are not closing off the hole between the atria and the ventricles, and there can be blood leaking backward. So it's really important we have a forward flow of blood through the heart, and the valves really ensure that that happens. So we have the right AV valve and the left AV valve. Another name for this is the tricuspid valve, and the left one is the mitral valve. And then we have valves on the base of the arteries leaving the heart. We have the pulmonary valve here at the base of the pulmonary artery, and we have the aortic valve, which is not shown here, but it would be at the base of the aorta here. And all of those valves prevent blood from flowing backward into the heart, or out of the heart into the vessels, and from the ventricles back to the atria. We don't want to see backward flow. So again, the left side of the heart we call the pulmonary circuit because it involves moving blood to the lungs. And the left side of the heart we call the systemic circuit because it's moving blood to the body tissues. So here we can see the lungs are shown here. So the right side of the heart has the deoxygenated blood, which is shown in blue, going to the lungs, picking up oxygen, bringing it back to the left side of the heart, which goes to the ventricle and then is pumped to all the vessels, all the arteries, and then capillaries of the body. So the coronary circulation focuses specifically on the circulation of blood over the heart muscle. Because the heart is a very hard-working muscle, it keeps us alive on a second-to-second basis, we want to be sure that we have good coronary circulation. So we have arteries, coronary arteries that branch off the aorta, and they provide oxygen and nutrients to the heart muscle. And then we have the coronary veins that receive the used blood that the heart has used and returns that back to the right atrium. So here's the coronary circulation. You can see the red vessels are the arteries that branch off of the aorta, and they supply the heart muscle tissue. And these are the arteries that contribute to heart attack. If you get a clot in an artery serving the heart muscle cells die and they can't pump effectively, and that can be deadly depending on where the clot is and how much of the muscle cells are deprived of oxygen. So it's very important that we very quickly diagnose symptoms of a heart attack and resolve that clot as quickly as we can to make sure that we save the heart muscle. Here's an angiogram where they'll actually inject a dye running through an artery in the leg, the femoral artery, which is in the groin. They run a catheter all the way up the femoral artery, going backward down the aorta into the coronary arteries, and then they inject a dye into those arteries, and they can visualize those vessels, and they'll look for any narrowing. So here we can look along this wall, and here I see a narrowing right here, so that might be an indication of heart problems beyond that narrowed spot. But we can see that the dye continued on, so that narrowing is not preventing fluid from passing, so it's probably not causing any issues for this patient. But it's important that we look for areas that show no dye passing through, which would indicate that that narrowing is not going to allow blood to flow through either. So heart catheterizations are really important diagnostic tools in looking for heart disease and looking for potential blockages. And in some cases, they can go in at the same time as they're doing the heart catheterization. They can, on that catheter, there's a balloon which they can inflate, which will push any narrowed portions of the artery wall, can push that to the side, and then they leave a little screen in there. It's a mesh screen called a stent. And that's going to keep that area open because it's like a little cylinder of mesh that keeps that area of the artery open so blood can continually flow through. And some of these stents are coated with an anticoagulant to prevent blood clotting, but most oftentimes the patient, every time I should say, is going to have to take some type of blood thinner to prevent any extra clotting around the stent. So that's just a kind of a side effect, or not a side effect, but a treatment after having a stent placed is taking a blood thinner like Coumadin, warfarin, even low-dose aspirin to prevent any clotting from occurring around that stent. But if a vessel is too narrowed and they can't get the balloon in there, then they would have to do open heart surgery, which we call coronary artery bypass grafting, where they're going to create a new vessel, take a vessel from the leg and have it go around that area that is blocked. So here we can see it commonly they take branches of the saphenous vein in the leg, and they will take that vessel, and if here's the blocked portion of the artery, they'll just bypass that so blood can flow from the aorta around that narrowed portion, and it still feeds the heart muscle. So this is a very common procedure around the country. It's been really specialized, and we have great outcomes. Even with the worst of patients, we see really good results as long as they watch their diet and try to prevent any new narrowing from happening. It can be a good outcome for patients. But if we look at the number one risk factor for needing coronary bypass surgery or even heart catheterization is smoking. Smoking causes or interferes with our ability to break down cholesterol and prevent plaque buildup in our arteries. So smokers are very much at risk for blockages, either in the veins or the arteries. So high blood pressure is a symptom of smoking over the long term. Clot formation anywhere in the body is much higher among smokers. So most of our patients we see that are needing bypass surgery have lifelong obesity or are heavy smokers. And we see blockages, occurring throughout the body because of the effects of nicotine and all the components of cigarettes contributing to high cholesterol and blockages. So if we look at the heart chambers and how they move blood through the system, we call that the cardiac cycle. So when we use the term systole, systole just means that the ventricles are contracting. So if we're looking at ventricular systole, it means the ventricles are contracting, they're moving blood out of the heart. Atrial systole refers to the atria contracting and moving blood from the atria into the ventricles. So we see this continuous cycle occurring in the heart to move blood. So the first part is we have diastole, where the atria and ventricles are both relaxed and blood is returning to the heart from the lungs and the body passively. So there's nothing actively pushing that blood in the heart, via contraction of the atria or ventricles. The atria and ventricles are relaxed. And then as those ventricles fill with blood, then the atria contract to fill up the last 20% or so of those ventricles. We call that atrial systole, when the atria are sending the last bit of blood to those ventricles, forcing the valves shut. Then the ventricles contract and they force that blood out of the heart via the aorta on the left side of the heart and the pulmonary artery on the right side of the heart. So the control of this process of systole and diastole is through an electrical system, which we call the internal conduction system, and it starts with the SA node, the sinoatrial node. And if we look at the conduction system, we'll see a cluster of cells in the upper wall of the atria called the SA node, which sends an electrical impulse across the atrial wall to the left atria down to the AV node, and this causes the atria to contract. And then that impulse travels down the middle of the ventricles, in between them, via the ventricular septum, and then up the sides to finally cause the ventricles to contract. So we see atria contracting before the ventricles. So that allows time for those ventricles to fill with blood. So we see this pathway. And if people have damage to cells along the pathway because of a heart attack and lack of blood flow to some of these cells, we're going to start to see abnormal heart rhythms because there's some damage to the conduction pathway. Some common heart rhythms we see as people age are atrial fibrillation, where the atria contract more often than they should, and that causes blood to not completely empty from the atria and fill the ventricles because they're not completely filling before they're contracting. So that is a risk factor for forming clots, and those people also with atrial fibrillation need to go on a blood thinner because they're going to have an irregular heartbeat because that impulse is not reaching the ventricles with every firing of the SA node. When someone has a pacemaker put in, they're actually stimulating that SA node should it not fire appropriately, which would cause sudden cardiac death. Some people have, if this conduction pathway is damaged, the pacemaker will not only control the atria, but it'll also control the ventricles. So sometimes the atria, or the pacemaker just controls the atria, sometimes it controls both the atria and the ventricles. So when we use an AED, an external defibrillator, we are trying to shock that SA node to function properly. Some people get into an abnormal rhythm with intense exercise or sometimes just spontaneously coming out of nowhere, and then we use the AED to shock that rhythm, shock that SA node back into the proper functioning and the proper rhythm. But then in the future, they're going to have a pacemaker put in to make sure that that doesn't happen again. So if we look at heart function, a common thing we look at is an EKG, which is going to tell us how the atria and ventricles are operating. So this first part of an EKG, the P wave, occurs when the atria contract. So we look for a normal P wave over a normal period of time, which would be 0 to 0.2 seconds, and as long as we see that, we know the atria are doing their job. Then the QRS complex refers to when the ventricles are contracting. So again, we're going to look at that time period from when the ventricles start to contract to where they finish. And as long as that is an appropriate time, we can say the ventricles are doing their job and they're healthy. And then the T wave is the time that the ventricles are relaxing, getting ready for the next cardiac cycle. So again, we want to make sure that that T wave shows time for the ventricles to contract, and it's the right shape and the right size. So a lot of analysis occurs over this EKG because it tells us what's going on electrically in the heart and if there's any type of damage that might affect this. Whenever we have a patient in the hospital that has chest pain, the first thing a doctor is going to order for that patient diagnostically is going to be a 12-lead EKG to analyze this rhythm and see if there's something that's happening in the heart that's affecting its electrical conduction and function of the heart. Another factor that we look at cardiovascular risk and function is blood pressure. We want to make sure that the pressure against the walls of our arteries is within a reasonable range, and the average is 120 over 80. But anything over 139 we consider to be high blood pressure for this top number. So we're always looking at that as an indicator of cardiac health. And it's important that we have and know what our blood pressure is. So typically we take blood pressure in the brachial artery, so that's the upper arm, that's closest to the heart. And that top number we call the systolic pressure. And that's when the ventricles are contracting. That's when we see the highest pressure in that brachial artery. So that's the top number. And then the bottom number is when when the ventricles are relaxing. So this is the lowest pressure number that we should see, and the normal number for that is 80. So the top number is always going to be higher than the bottom number because the top number is when the ventricles are contracting, and the bottom number are when the ventricles are relaxing. So we would see a higher blood pressure number if someone has narrowed blood vessels, because the pressure in there is going to be higher because there's a smaller lumen for that blood to flow with each heartbeat. So here's some numbers kind of showing you what is ideal. Ideal is anywhere from 110 to 120. Anything over 120 to 139 we consider high normal, and anything 140 or higher is considered high blood pressure. And we can have high blood pressure occasionally, if you're going through a stressful time, but if we see, high blood pressure continuing over a period of time, that's when patients really need to be seen and go on a blood pressure lowering medication, because over time that heart muscle is working really hard to push blood against these high pressures. And that's why we call it the silent killer, because people don't know that they have heart disease until the heart starts to wear out and its function goes down because of lifelong high blood pressure. And most people don't control their blood pressure well that are on blood pressure medications, because the doctor can prescribe a certain dosage and that can work well for a period of time, but as people's lifestyles change or heart function changes with aging, they need to get those blood pressure medicines adjusted. So it's very important that people go to the doctor, get their blood pressure checked, and check their blood pressure in between doctor's visits to make sure that their blood pressure medicine is working appropriately. That's why it's nice to have those blood pressure machines in Walmart and Walgreens so people can check their blood pressure on a regular basis. And those that have high blood pressure problems typically have a blood pressure monitor at home. And you can pick those up relatively cheaply, at Walmart to make sure that you know your blood pressure. And then the last little bit of the cardiovascular system is the lymphatic system. These are special vessels that run alongside our capillaries that pick up extra fluid that leaves the blood and enters into the tissue spaces. And if you've ever had a swollen ankle from twisting your ankle, you know that edema is when we have too much fluid in the tissue spaces, and the lymphatic vessels just can't keep up with taking that fluid out of that and returning it to the blood. So the major function of the lymphatic system, these vessels, is to return this fluid that leaks out of our capillaries and putting it back into the bloodstream. And we also find that the lymphatic, there are special vessels in the capillary beds of the digestive tract that help break down fats in the small intestine. And then we know that they also, in the process of taking this interstitial fluid back to the bloodstream, they carry any type of leaked microorganisms that might be entering into the tissues. Like if you have an infected ankle or an infected cut, the lymphatic system will deliver, or the blood will deliver immune cells to deal with that infection, and the lymphatics will help carry those dead cells or disease-causing microorganisms out of that space and back to the heart. So it passes through lymph nodes on its way back to the blood supply, this fluid that is being returned to the blood. And these lymph nodes can sometimes become swollen because they are filled with dead cells and microorganisms, and that can be a sign of infection. So we're always, when people come into the hospital or to the clinic, not feeling well, they're always going to feel those lymph nodes as signs of infection if there's a lot of cells that are clogging up the lymph nodes. And sometimes we have like the tonsils, which are a type of lymph node, a specialized lymph node, become so clogged with bacteria that a person always has a low-grade infection, where it's better to remove the lymph node than to keep it there, because it becomes a source of infection rather than fighting infection. So other lymphoid organs we have are the thymus gland. We saw that with the endocrine system, that helps develop our immune system. But by the time we're adults, the thymus gland has pretty much turned to fat, and it's no longer working to improve our immunity. The spleen is another lymph organ. It's very important for producing immune cells and storing immune cells. And if we get in a bad car accident, the spleen is very highly vascular, has lots and lots of blood vessels, and it can burst in high impact accidents, and people can lose their spleen. And as a result of that, that puts them at higher risk for certain viral infections. So we want to keep our spleen if possible, but we can live without it. But it would just be important to be immunized, against those certain viruses that put people more at risk if they've lost their spleen. Peyer's patches are clusters of lymphatic tissue that help prevent infection along the small intestine. As we know, our food is definitely not sterile, so we can sometimes, ingest infected food that can unfortunately sometimes pass through the intestinal wall, and we have these Peyer's patches there to help protect us from infection if anything should get through the intestinal wall and prevent us from becoming septic, where we have bacteria throughout the body. And then our red bone marrow, we know, is a source of new immune cells. So we're constantly producing red and white blood cells in our red bone marrow. Remember, that's found at the ends of our long bones, in that spongy bone region of our bones. So this shows the distribution of lymphatic vessels. You can see all these lymph nodes kind of where they're clustered. So in your side of your neck, you can feel those lymph nodes if they're swollen, or in your armpit or in your groin. Those are common locations for swollen lymph nodes to be noticed by a doctor or by a person when they're just showering. They might notice that they're a little bit enlarged. So it's important that we understand the role of lymph nodes, as far as they are a filter for fluid that leaks out of our capillaries and fluids that are produced by damaged tissues. So if they are blocked, that's going to cause fluid to remain in those areas and cause edema. And again, to get our lymph vessels moving fluid, our skeletal muscles help do that. So it's important that we move around, get exercise to have good lymph flow and protect us from infection. People find that they have much better immunity when they're exercising because of just, the factor of increasing lymph flow. And also we know that exercise helps boost our, neurotransmitter production and our hormone production. So it does a number of things for keeping us healthy. But we know cancers in certain parts of the body too can, like if a woman has breast cancer, those cancer cells can leak out into the interstitial fluid and be picked up by the lymph vessels and cause a swelling in the armpit. And that's a common reason why some women come into the clinic, is because they've got a swelling in their armpit, and they'll commonly link that to a tumor in the breast. And they'll have to remove not only the breast tumor and the whole breast in some cases, but they'll also have to remove lymph nodes in the armpit. And that can cause a lot of edema in that arm then, because there's less ability for the fluids in the arm to be returned back to the blood, because we can see right here is where these lymph vessels connect with the blood. and as a result the arm is full of fluid and they have a lot of trouble keeping that arm healthy in terms of good blood flow and less fluid buildup. So sometimes you'll see women with this problem wear a special sleeve on the arm that has had the lymph node removed. But the good news is these lymphatic vessels will grow back, and sometimes that can improve over time after they've had surgery to remove the lymph nodes after a breast cancer diagnosis. So it's important to understand for our online test just the basic structure and function of arteries, capillaries, and veins, basic structure, anatomy of the heart, how blood circulates through the heart, know the difference between the right and left circulation, what they serve, and where the blood comes from, and understanding the SA node's role in controlling the heartbeat, and blood pressure, what that top number is called and the bottom number is called, and also the role of lymph nodes and the lymphatic system in dealing with fluid and immunity. So that concludes our discussion of the cardiovascular system.